So next I would like to introduce Dr. Mary Hulihan. She is the health scientist in the Blood Disorder Surveillance and Epidemiology branch of the Division of Blood Disorders and Public Health Genomics at the Center for Disease Control and Prevention, also known as CDC. Thank you so much for joining us, and I'll turn it over to you, Dr. Hulihan.
Thank you so much. Thanks everyone for having me here today. I'm really excited to have this opportunity to talk to you about CDC's sickle cell disease surveillance system, better known as the Sickle Cell Data Collection Program, or SCDC. I think if we can go to my slides, we can get going. Awesome. Wonderful. Okay, so that's our name, and you can go ahead to the next slide, please. So what is the Sickle Cell Data Collection Program, or SCDC? It's a public health surveillance system, and that means that it's an opportunity to collect health information about people with sickle cell disease to study the long-term trends in diagnosis, in treatments, and in healthcare access for people with sickle cell disease in the United States. And I want to emphasize that the goal of SCDC, which is a little different than a lot of other data collection efforts, is to include all individuals with sickle cell disease in the system. That means it doesn't matter their age, what type of insurance, what their disease severity looks like, or where they receive their health care, but really to include all individuals with sickle cell disease to better understand their diagnosis, treatment, and healthcare access. Next slide, please. So what is the purpose of SCDC? First, the program supports the complex infrastructure that is needed to collect data. This is a big undertaking. It requires a lot of data expertise, epidemiology expertise, legal expertise. But that, as with all surveillance systems, that SCDC doesn't end once the data is collected. In fact, that wouldn't be appropriate. That wouldn't be the way public health works, for it to end once the data collected. Instead, the next step is for that information to be used to better understand the healthcare and health outcomes of all individuals with SCD. And a crucial part of the program is the dissemination of that information. And it's disseminated in ways that inform policy, inform healthcare standards, inform ways that improve and extend the lives of people with sickle cell disease. So these can be policies at the local level, such as in a single hospital or healthcare system. These can be policies at the county level, at the state level, or perhaps even policies at the federal level that affect all individuals in the United States. Next slide, please. I want to talk to you a little bit also about the priorities of SCDC. So as I said, it is not just a data system, even though the name might make you think that. Instead, there really are 5 top priorities of SCDC. The first, the most basic, is to collect data. As I keep stressing, this is a complex process and involves many partners, many moving parts. It takes a lot of time to collect this data. It takes a lot of effort, because while there are similarities about the data that is available and the way it is collected from state to state, there are also a great number of differences. So we continue to strategize about ways to modernize and standardize the process so that the information we're collecting from all states can be used to work together to better understand sickle cell disease. And then we need to use that data. The benefits of the system are only going to be realized when that data is put to use. Next, we must engage with the sickle cell disease community. And this is the sickle cell disease community as a whole. So we're talking about people living with sickle cell, their families, their caregivers, community and advocacy organizations, healthcare providers, teachers, school systems, really all of the partners that are needed to be given the opportunity to understand and use this data in ways that can positively impact people living with sickle cell. The fourth priority is communications. And one of the best ways to engage with your partners, with the sickle cell disease community, is to communicate information and answers learned from using the data and release that information in many different ways. So release it through presentations for scientific communities, through webinars, through podcasts, social media, scientific publications, local health fairs, ways to make sure that everyone who is interested or needs to know about sickle cell disease can, and that that information can be brought to them in ways that they are interested in learning about. And then finally, policy. Again, just to emphasize, this information is meant to educate and inform policy. Policies in the emergency room, state level policies. It could be policies that already exist but maybe need to be improved upon, or it could be ones that are in the planning stages. And this informing and educating of decision makers is a team effort. It really requires everyone in the sickle cell disease community working together to make a difference. Next slide, please. So now that I've provided a brief overview of the way SCDC is structured, let's talk a little bit more about which states are currently funded to be a part of this program and how they are turning data into action. So since September of 2023, we have had 16 states participating in SCDC, and we estimate based on census data and just kind of looking at general demographics of these states, that those 16 states probably account for at least 50% of the US sickle cell disease population. And we're working with all of these different states because they each bring unique perspectives, experiences, and expertise to the project. As part of the project, we try our best to make sure that there are lots of opportunities for those unique attributes of the states to be shared from state to state and for there to be ongoing interaction with and learning from each other across states. Next slide, please. Is this program actually making a difference? So I have 3 examples to share with you today of what is taking place. I will say these are kind of just the tip of the iceberg. There is much great work going on across all states, even those who just started participating a few months ago. But here today we have California, who's been receiving funding for their surveillance for more than a decade. Using SCDC data, it was determined that more than 30% of California's sickle cell population resides in LA County. LA County is a huge county. It houses a lot of the population in general of the state, but also a great deal of the state's sickle cell population. We also know that the only comprehensive adult sickle cell program in that county closed back in 2009. And so as a result, the adults living there were either traveling great distances to see a sickle cell specialist, or probably more likely, they were only receiving their healthcare in the emergency department. So that information, the story, the entire story, so both the data and the lived experiences were used by a team of partners to inform county-level policymakers about the lack of access to care and the need for support of adults living with sickle cell. As a result, a new sickle cell clinic opened in the South Central Los Angeles region to serve the needs of people in that area. Next slide, please. We know that the challenges that adults face with sickle cell and accessing healthcare is well documented. There are numerous papers about it. There has been a lot of research about it. But I think it's important to acknowledge that children with sickle cell face barriers too. So this very complex map of the state of Georgia has lots of information. It's showing where children with sickle cell disease live in the state. So the darker blue counties have a higher number of children. It is also showing you where there are sickle cell disease clinics in the state. You'll see yellow stars. Those are clinics that provide care on a daily basis. And then there's also yellow circles. And those are clinics that provide care on a more periodic basis. So that might be weekly or monthly. Then the Georgia team looked at how many children in the state live more than 1 hour drive from a sickle cell clinic. And that's what you see represented by the gray lines on the map. So the take-home message here is that there are a lot of children with sickle cell disease living in the state of Georgia that live more than a 1 hour drive from the closest sickle cell disease specialist. So we're with sickle cell disease, healthcare may be needed quite frequently. So we're talking about the need for families, for loved ones, for caregivers to drive to these clinics fairly regularly in some cases for families. Again, these data, along with the stories of how these long distances have impacted families in the state, were used to establish additional care models. They've established new clinics in the areas with greatest need. They've increased the availability of telehealth services. They've increased mobile health services, especially for people living in the more rural parts of the state. One more time, this is a completely team effort. There were a lot of different groups that have come together to make this, to make all of these changes in the state, to use data, to tell stories, to talk to people who are able to make changes. Next slide, please. So my third example today is a joint effort that's taking place across 5 of the states participating in SCDC. This is California, Georgia, Michigan, North Carolina, and Tennessee. This is unpublished data, so I'm just sharing with you kind of the high-level messaging here. But together, these states looked at enrollment in Medicaid for babies born with sickle cell disease in each of the states, those babies identified through their newborn screening programs. And they found that more than 80% of the newborns living with sickle cell disease were insured by Medicaid for at least 1 month during their first 3 years of life. These findings, again, are currently under review for publication, so the impact of these results is not yet known. But the teams in these states are thinking about ways these findings can inform their work with state Medicaid offices, with other partners, to hopefully play a role in enhancing the receipt of recommended preventative services. These services that are so crucial in making sure that babies have as healthy of a start as possible to life. Services that are specific to sickle cell disease, such as starting penicillin prophylaxis, stroke screening, as well as the recommended preventative services for all children, such as immunizations and hearing services. Slide 9. The next slide, please. So finally, I'd like to close today with recognition that the work that is being done through CDC funding of SCDC provides lots of opportunity to inform and be informed by the great work around sickle cell disease that is being led by our colleagues throughout HHS. I know you're going to have opportunities to hear more from them following my presentation. So I want to leave you with an example of how CDC and HRSA's efforts might work together as we move forward. And this is using the state of Alabama as a model. So Alabama participates and receives funding both from CDC and from HRSA through their treatment demonstration program. The grantee for the funding for both of those is the University of Alabama at Birmingham. And so the data they collect from the CDC project helps the state determine where people with sickle cell live, where they receive their health care. So the map on the left shows you that there are about almost 4,500 people in Alabama with sickle cell disease. And you can see which counties they live in. The darker green counties have the most number of individuals living with sickle cell. Again, this is work that's made possible through the CDC funding of the sickle cell data collection program. And then on the right, you can see how that data is used in efforts that are led by HRSA through the treatment demonstration program, and using that information about where people live to help increase provider knowledge and services in those locations identified as being the most in need. So the idea here is that UAB Birmingham, again, the grantee, connects with providers and service locations in Mobile, Montgomery, Selma, through their HRSA-funded efforts to create this network of education, communication, and information, with the intended result being that more people living in those parts of the state where the highest numbers are now can have access to appropriate healthcare in areas where they live and work. Final slide, please, the next one. So I hope this very brief overview has helped to provide an explanation of how SCDC works, where it's up and running, and how the program is realizing the goal of improving the lives of people with sickle cell. There are, as you know, as you are the experts, that there are so many exciting developments in sickle cell disease at the moment. And I truly think that SCDC can be one of the ways to make sure that these developments are available and accessible to all those who are interested in learning more and being educated about these new developments and in perhaps benefiting from them. Thank you so much.
Thank you so much, Dr. Hulihan. We have a few questions from the audience. First one, how did we get our state that isn't currently a part of this program to be involved?
That's a great question. I think there are a couple of things in the short term. Your state is more than welcome to reach out to me. We have some materials on our website for states that are not currently participating, but maybe want to do some of the initial kind of legwork to get a team up and running and start exploring the opportunity. So that's something that can be done short term. Long term, we are hopeful that there is the opportunity to fund more states through additional grants, through additional programs. All of the states are funded the same way. We put out a funding opportunity announcement. Anyone who is interested can apply for that funding. It goes through a review process, and those who receive the highest score are funded to do the work. That's how the current states were funded. That's how all programs at CDC work. And that is what we are hopeful that there will be the opportunity to continue doing in the future.
So, we have another one from the Q&A. Does the CDC collection program collect information from the prisons on the number of inmates with sickle cell disease and those who receive care outside their facility?
That's a really great question. I had a very lengthy discussion about this yesterday with some of our partners in California. It is a question that comes up often. I will tell you the current information we have does appear to allow us to know if someone enters the emergency department or the hospital. We do have some indication of the data of either that their care is being funded by insurance that is provided to individuals who are incarcerated, or in some cases we have information that shows the type of transport that was used for someone to come into the hospital or emergency department, which could indicate transport from prison or other incarceration. So we don't at this point have an exact answer for you, but it is something we are very much looking forward to further exploring, better understanding, and using that information to educate the judicial system and the healthcare system within the prisons about ways to improve care for incarcerated individuals with sickle cell disease.
Awesome. Thank you so much, Dr. Hulihan, for coming to speak with us. I know this is an important program and really interesting, especially from an epidemiology standpoint from sickle cell disease.
Thank you so much, Mariah. I appreciate it.